Good morning, everyone. Our assigned topic is all about the bladder cancer. Epidemiology. Cancer of the urinary bladder is more common in people aged 50 to 70 years. It affects men more than women and is more common in whites than in African Americans. Bladder cancer is the fourth leading cause of cancer in American men, accounting for more than 12,000 deaths in the U.S. annually. Bladder cancer has a high worldwide incidence. Bladder tumors account for nearly 1 in 25 cancers diagnosed in the United States. So there are two forms of bladder cancer. The first one is the superficial, which tends to recur and affects only the urothelium. And the other one is the invasive, a bladder cancer that spreads from the urothelium to the muscle layer. About 80% to 90% of all bladder cancers are transitional cell, which means they arise from the transitional cells of the bladder. The remaining types of tumors are squamous cells that develops in the bladder lining in response to irritation and inflammation, and over time this becomes cancerous. And the other one is the adenocarcinoma that develops from granular cells. Research has demonstrated that many individuals with bladder cancer for which a total cystectomy is required go on to develop upper urinary tract tumors. So these are the risk factors for bladder cancers. First, we have the cigarette smoking, risk proportional to number of packs smoked daily and number of years of smoking. Environmental carcinogens, dyes, rubber, leather, ink, or paint. Recurrent or chronic bacterial infection of the urinary tract, bladder stones, high urinary pH, high cholesterol intake, pelvic radiation therapy, and cancers arising from prostate, colon, and rectum in males. And these are the signs and symptoms. So patients who have a bladder cancer may experience a visible, painless hematuria. An infection of the urinary tract is a common complication, producing frequency, urgency, and dysuria. And the pelvic or back pain may occur with metastases. The treatment of bladder cancer depends on the grade of tumors or the degree of cellular differentiation, the stage of tumor growth or the degree of local invasion, and the presence or absence of metastases, and the multicentricity of the tumor. The patient's age and physical, mental, and emotional status are considered with determining treatment modalities. So these are the assessment and diagnostic findings. Urine samples for cytology to detect the presence of abnormal cells. However, its use in the diagnosis of bladder cancer is controversial due to its lack of sensitivity. A midstream urine sample for culture for sensitivity, a full blood count for anemia, a full biochemistry screen for renal function, a liver function test, a KUB X-ray, and intravenous orogram. Non-muscle invasive cancer. These are found in the inner layer cells of the bladder. So the treatment includes transurethral resection of the bladder tumor. This is a surgical procedure that is used to diagnose and to remove cancerous tissue from the bladder. We also have the adjunct intravesical chemotherapy, and this treatment allows the drugs to put into the bladder through a catheter, and it kills actively growing cancer cells. Adjunct intravesical immunotherapy with BCG vaccine as both induction, and maintenance. BCG is now considered the most effective intravesical agent for recurrent bladder cancer, especially superficial transitional cell carcinoma, because it is an immunotherapeutic agent that enhances the body's immune response to cancer. The choice of further therapy depends on the patient's risk of tumor recurrence and/or progression. Regular cytoscopy may be necessary. Their frequency determines by the risk of recurrence or progression. Muscle invasive cancer. This also includes the cytoscopy, transurethral resection, chemotherapy, and radiotherapy. You also have the partial or total cystectomy, or a surgery to remove the urinary bladder, as the preferred curative treatment. If the tumor is inoperable, patients would commence palliative therapy without surgical intervention. Radiotherapy can be given instead of surgery to avoid removal of bladder. Cystectomy and urinary diversion. Radical cystectomy involves, in male, removal of bladder plus prostate, upper part of urethra, seminal vesicles, and lymphatics. In females, removal of the bladder plus part of the urethra, the uterus, fallopian tubes, ovaries, anterior vagina, and pelvis with lymphadenectomy. These are the nursing management for patients undergoing a cystectomy. So we have the preoperative interventions. First, we need to educate patients on the following. For the surgical procedure, we need to reinforce knowledge about the procedure, discussing what to expect during and after the procedure, and what are the possible complications that may occur. We also need to prepare the client physically, emotionally, and mentally for the surgery, as well as the equipments needed. For the stoma, we need to educate them by describing the physical appearance using a diagram, videos, and written information. We also need to educate the patients on the stents inserted into the stoma to protect the anastomosis between the ureter and intestine, the ostomy and related equipment, and wearing of a bag. We also need to educate the patient on the daily activities. There is no need to alter the clothing, and the patient can continue to bath or shower. For the stoma site, it's usually on the abdominal wall below the waist on the right hand side. Plan with the patient so that the side does not interfere with standing, lying, or sitting. Also mark with enable ink. The skin is tested with adhesive for any allergies. Bowel preparations, this is not always necessary and is determined by the surgeon's preferences. Preoperative advice from the physiotherapists and dietitians are necessary. Monitor the following: the respirations of the client, color, level of consciousness and appearance, pulse oximetry for oxygen saturation levels, pain level, and the stoma. Place the patient in the semi-Fowler's position. Administer prescribed oxygen and patient-controlled anesthesia and assess its effectiveness. Physiotherapy and early mobilization, and the regular use of the incentive spirometer with breathing and coughing exercises. You also need to monitor the signs of hypovolemic shock due to hemorrhage. For the stoma, it should be pink to red in color and moist. Dark red or blue-gray in color could indicate ischemic changes. It should be flush with the skin. So monitor also the following: color and appearance. Check 2 hourly for the first 24 hours and then 4 hourly for 48 to 72 hours. Monitor the signs of prolapse, retraction, or separation of the peristomal skin from the stoma. You also need to monitor the degree of edema percent. This gradual decreases over 6 to 8 weeks, and monitor whether the appliances fits with edema percent. As the edema decreases, the stoma will need to be remeasured, and the aperture in the stoma appliance reduce accordingly. The uretic stents are removed at 10 to 14 days. They may fall out into the pouch. The sutures are dissolvable. Persistent redness, broken skin, or complaints of discomforts or allergic reaction should be investigated and rapidly treated. Get patients to look at the stoma as soon as possible, as this assists them in adjusting to their altered body image. The pouch should be changed as needed, usually 3 days post-operatively. Frequent emptying prevents leakage of urine onto the incision. Urostomy appliances can be changed every 2 to 3 days. In changing the appliance, you need to remove gently to prevent trauma to the surrounding skin. Gently wash skin with soap and water and dry the area, and ensure the new appliance has been applied correctly. Also, we need to monitor the urine, the output, which should be recorded on the fluid balance chart. The presence of mucus, this originates from the segment of bowel used as the conduit and may continue indefinitely. Increased output may be due to leakage, causing peritonitis, obstruction by mucus or edema, dehydration, or renal failure. You also need to educate the patient on ostomy self-care skills, emptying the appliance and attaching it to straight drainage, care of the stoma, and assessment of the normal appearance, measuring the stoma and adjusting the size of the appliance. Skin care. Control the odor. Noxious odor can occur as a result of poor hygiene, alkaline urine, normal breakdown of urine or ammonia, concentration of urine because of insufficient fluid intake, and ingestion of certain types of foods such as eggs. Deodorant tablets can be placed in the pouch. Reused pouch should be washed thoroughly with soap and lukewarm water, and then soak in dilute white vinegar or a commercial deodorant product for 20 to 30 minutes. Outline the complications, give dietary guidelines, explore potential problems, and the stoma nurse will provide further education on the stomach care. We also need to monitor the bowel sounds, possible paralytic ileus, commence oral fluids, followed by a light diet. And for the wounds, we need to monitor the signs of infection. Remove the wound drain if present, usually at 48 to 72 hours. Remove sutures or staples after 7 to 10 days. For psychological care, aim to promote a healthy body image. We need to give a positive encouragement, acceptance of the stoma, contact with the stomach nurse, and support groups, and family support and involvement in care. And lastly, give a discharge advice. The preparation for the first month at home, the transfer of skills to the home situation, community resources, where to obtain supplies, the activity levels and exercise, sexually, outpatient appointments, the stoma nurse contact details, and the support groups.
Good morning, everyone. I'm going to discuss about the bladder cancer, this process. So, for the bladder cancer, it is usually transitional cell, which is the urothelial carcinoma. Patient usually present hematuria most commonly or irritative voiding symptoms such as frequency and urgency, Later, for urinary obstruction that can cause pain. So for predisposing factors, we have males 50 years above, developing countries usually due to endemic schistosomiasis, cancer arising from prostate, colon, and rectum in males, in heredity. And for the primary factors of precipitating, we have the smoking, which is known to increase the incidence of bladder cancer, which is fourfold relative to non-smokers. In early, half of all bladder cancers can be attributed to smoking due to its inductions of chronic inflammation. And individuals at higher risk include those who work in dye, rubber, leather, aluminum industries, or painters. Also, we have recurrent or chronic bacterial infections of urinary tract. We have the bladder stones, high urinary pH, high cholesterol intake, and the pelvic radiation therapy. For the bladder cancer, mechanism underlying the formations of the urothelial carcinoma are many and complex, and the details of which are still not fully understood, but several mechanisms, however, have been elucidated. So we have the two pathways are used to describe the development of bladder cancer. We have the invasive pathway and the non-invasive papillary pathway. And it has been suggested that the slow cycling urothelium of the bladder gives rise to the papillary pathway. And the urothelium is the epithelial layer composed of basal cells, intermediate cells, and umbrella cells that line the bladder tissue, which is normally replaced 6 to 12 months. So the tissue contains urothelial stem cells with self-renewing capabilities, making it much more susceptible to malignant transformation. So for cancers develops when hyperplastic urothelium begins to grow towards the lumen of the bladder. This is often the result of genetic alteration in several proto-oncogenes, including the fibroblast growth factor receptor 3. And also, we have the Harvey-Rat sarcoma viral oncogene. So these are the mutations that occur in urothelial hyperplasia, which is 70% of papillary tumors occurs. Both oncogenes are known to play a role in the activations of the rat sarcoma. We have also the urothelial dysplasia, this is the non-muscle invasive cancers, troublesome because due to their high recurrence rate. However, they are often associated with positive prognosis. Conversely, invasive urothelial cancer originate from 1 to 2 mechanisms. We have the severe dysplasia or the carcinoma in situ. So for the result of the inactivation of this tumor protein or retinoblastoma pathways with a tumor inhibiting effect, so the mutations are prevalent in both invasive and non-invasive cancer types. We have a 20% present cases of these two. Many cell types promote the development, invasion, proliferations, and metastases of bladder cancer, but cancers alter their microenvironment by recruiting and activating stromal cells, adipocytes, and fibroblasts, inflammatory cells, as well as mesenchymal and endothelial progenitors. And they alter the environment so it resembles periods of wound healing induced by release factors. It has been implicated in tumor growth and metastasis due to their role in tissue repair. So for the signs and symptoms, the commons are we have the painless hematuria, the frequent urination, painful urination, and the pelvic or back pain. And for the medical management, we have the urine samples for cystology to detect the presence of abnormal cells. However, its use in the diagnosis of bladder cancer is controversial due to its lack of sensitivity. a mainstream urine sample for culture for sensitivity, a full blood count, a full biochemistry screen for renal functions, a liver function test, a KUB X-ray and intravenous urogram, a cystoscopy and examination under anesthetic, biopsy and histological examination, CT scan, MRI scan, pelvic ultrasound, bone scan, and the internal examination of the rectum in men and the rectum and vagina in women. Both are close to the bladder and are palpated for any thickening or lumps. For the treatment, we have cystectomy and the transurethral resection of bladder tumor. And for the therapies, we have chemotherapy, immunotherapy, and the targeted therapy. And for the nursing management, for patients who require radical cystectomy with urinary diversion, offer support and reinforcement of the information, be sure what to expect, involve another family member in the preoperative educations if it is needed, arrange a preoperatively visit by someone who has adjusted well to similar diversion. And for if any type of stoma is to be created, arrange for preoperative visit from the enterostomal therapist. The enterostomal therapist can assist in the selection and marking of the stoma site, although the stoma site is somewhat contingent upon the type of urinary diversion to be performed and can introduce the patient to the external urine collection pouch and related care. For the preoperative interventions, administer bowel preparation as prescribed, which may include a clear liquid diet, laxatives and enemas, and antibiotics to lower the bacterial count in the bowel. Assist the surgeon and the enterostomal nurse in selecting an appropriate skin type for creations of the abdominal stoma. Encourage the client to talk about his or her feelings related to the stoma creation. For the post-operative intervention, we have monitor vital signs, assess the incision site, assess the stoma, should be red and moist every hour for the first 24 hours. Monitor for edema in the stoma, which may be present in the immediate post-operative period. If the stoma appears dark and dusky, notify the physician immediately because this indicates necrosis. Monitor for prolapse or retractions of the stoma. Assess for return of bowel function. Monitor for peristalsis, which will return in 3 to 4 days. And maintain NPO status as prescribed until bowel sounds return. Monitor urine flow, which is continuous 30 to 60 ml per hour following surgery. Notify the physician if the urine output is less than 30 ml an hour or if no urine output occurs for more than 15 minutes. Urethral stents of catheter may be in place 2 to 3 weeks or until healing occurs. Maintain stability with catheters to prevent dislodgement. And monitor urinary output closely. Irrigate catheter if present gently to prevent obstruction as prescribed with 60 ml of normal saline. Monitor for hematuria, monitor for signs of peritonitis, monitor for bladder distension following a partial cystectomy, monitor for shock, hemorrhage, thrombophlebitis, and lower extremity lymphedema following a radical cystectomy. Monitor the urinary drainage pouch for leaks and check skin integrity. Monitor the pH of the urine. Do not place the dipstick in the stoma because strong alkali urine can cause skin irritation and facilitate cyst crystal formation. Instruct the client regarding the potential of urinary tract infection or the development of the calculusis. Instruct the patient to assess the skin for information and to monitor the urinary drainage pouch for any leakage. And encourage the client to express feelings about changes in the body image